Hi, I'm Dr. Henry Black, and I'd like to discuss three trials that have all focused pretty much on the same problem. That is what to do with diabetics with type 2 nephropathy or without type 2 nephropathy to see how aggressive control needs to be. This is the ACCORD study that was sponsored by the National Institutes of Health in the United States, the ADVANCE study from Asia and Europe, and AVOID, which was a smaller study with a surrogate endpoint done in the United States and Europe. The ACCORD and the ADVANCE study were both published in the same issue of the New England Journal last June, and the AVOID study was published at approximately the same time. ACCORD and ADVANCE had somewhat disparate results. In ACCORD, this was a factorial design where people were recruited, about 11,000. They had their lipids tightly controlled. They got either fenofibrate or placebo. They had their blood pressure tightly controlled to a goal of less than 120 systolic or less than 140 systolic. And then they had the hemoglobin A1C controlled to what was considered conventional, to less than approximately 7 milligrams percent, or aggressive, which was less than 6 milligrams percent. ADVANCE had a similar design. The ACCORD study was stopped early for the glucose control portion because there was an increase in death from all causes in the group with intensive control. The ADVANCE study, which was done in Asia, Europe, and a little bit in the United States, had a very similar design but had very different findings. In ADVANCE, everybody got the same sulfonylurea to begin with, but in ACCORD, it was up to the doctors or the investigators to decide what that regimen was, so long as that goal was reached. Now, the peculiar thing about ACCORD is that the primary endpoint was not reached, but within the primary endpoint, non-fatal MI was reduced statistically significantly. Yet, more people died in the intensive group than in the standard therapy group, including people dying of cardiovascular events. This doesn't compute if you think about this a little bit. In ADVANCE, they had a different finding. They did see about a 10% reduction in a primary endpoint, which was quite similar to ACCORD. And they noticed, and this is maybe one of the most important findings, that they did actually reduce nephropathy in people with type 2 diabetes. And we think nephropathy is a major microvascular event, but a major complication for people with diabetes. We have to reconcile this, and if we look a little more closely, we'll see that the people in ACCORD had much better control of risk factors, all risk factors, blood pressure and cholesterol, as well as hemoglobin A1C. And the death rate in both groups, the intensively treated group and the conventionally treated group, was about half of the death rate in ADVANCE. This is something that hasn't been pointed out very much, but whatever we were doing in ACCORD, we were had fewer deaths, even if the intensive therapy group for glucose wasn't coming out the way it would have been expected. The nephropathy finding has also other implications. ADVANCE defined nephropathy as increases in macroalbuminuria, doubling of serum creatinine, or renal death or death from renal causes, which brings me to AVOID. AVOID looked at the combination of an angiotensin receptor blocker, losartan at full dose, 100 milligrams per day, and then aliskiren, a direct renin inhibitor, was added, first at 150 milligrams a day, and then up to 300 milligrams a day, which is the maximum dose. This was just a 24-week study, but it did show statistically significant reduction in macro or microalbuminuria, defined pretty much the same way as was defined in ADVANCE. So if intensive therapy with two ways to block the renin-angiotensin system produces nephropathy, and nephropathy was reduced by aggressive blood pressure, aggressive glucose control in ADVANCE, maybe there's something here we need to sort of figure out. I think right now this is all an open question. The rest of the ACCORD study will be completed, we hope, in about a year or so, and we'll see whether aggressive blood pressure and aggressive lipid control will end up in reducing events. Right now, I think we have to be very careful of what we do with each individual patient and understand that aggressive goals may not always be right, but we need a lot more data to find out why they're not. Thanks very much.